Hello to everyone. I'm Paolo Ghia, Professor of Medical Oncology at Università Vita-Salute San Raffaele in Milan, where I'm Director of the CLL program at the affiliated hospital San Raffaele. And at EHA this year in Frankfurt, a number of abstracts have been presented updating studies on the use of combinations in frontline in patients with chronic lymphocytic leukemia, CLL. And in particular, we have heard the 6-year update of the CLL-14 study presented by Osman Al-Sawaf. And in this case, I just remind you what the study was about. It's a phase 3 international study where the combination, the fixed duration treatment with venetoclax for 1 year associated to obinutuzumab, the anti-CD20 antibody in the first 6 months, was compared to chlorambucil plus obinutuzumab. So we are talking about elderly patients. And the first thing that has been confirmed, of course, is that with the fixed duration, we do rarely see any adverse events in the long run with the long follow-up. And that's reassuring, and that's exactly what we expect when we plan to use a fixed duration treatment. The only issue that remains open is the issue of other malignancies. They are numerically higher in the arm where patients have been treated with venetoclax plus obinutuzumab. There is no statistically significant difference between the two arms, but still this is something that it's under scrutiny, and it is closely followed up also for the future. In terms of efficacy, we confirm, Osman confirmed the efficacy that we already have seen in the previous update of the study. Here, I remind you, it's a 6 years follow-up, so 5 years off treatment, so only 1 year of treatment, 5 years of treatment. And in this case, the PFS, the median PFS for patients treated with venetoclax plus obinutuzumab is 76 months, so more than 7 years. More than 50% are still progression-free at 6 years, exactly 53%. Osman also confirmed that patients with p53 aberrations tend to progress earlier, the median progression-free survival being 51.9 months, so a little bit longer than what previously presented at the earlier update. And p53 together also with unmutated immunoglobulin genes, it has been shown to be an independent negative prognostic factor for PFS. And in fact, also patients with the unmutated immunoglobulin genes tend to progress earlier than the remaining patients, and the median progression-free survival being 64.8. For patients with mutated immunoglobulin genes, those with a better prognosis, the median progression-free survival is not yet reached. What is interesting, more interesting probably for the daily use of the combination, is the time to next treatment. That the median time to next treatment has not yet been reached with venetoclax plus obinutuzumab, and more than almost 2/3 of patients, 65%, still don't need a treatment regardless progression after 6 years of follow-up, which is again quite reassuring. Some patients have progressed and also needed treatment, and the patients have been treated, unfortunately, I would say, most of them, almost 60% with the BTK inhibitor, so we don't have so much data about retreatment using venetoclax. That happened in 17–18% of the patients, which numerically are very few, like less than 10 patients. So for this, and to understand how we can reuse or utilize the same treatment, still we need time and further studies, because this is exactly another advantage that we could have with the fixed duration treatment, the possibility to reuse the same drug. Overall survival, there is no significant difference, but there seems to be a difference coming up. So in the subsequent follow-up, maybe we can see a difference, because the median progression-free survival is not yet being reached with both venetoclax plus obinutuzumab and chlorambucil plus obinutuzumab. There is a roughly 10% difference between the two arms. And then more interesting in this kind of studies is the evaluation of MRD. And what we learned from this study and from Ottman is that after 5 years, virtually all patients lost the status of minimal undetectable minimal residual disease. So only 7.9% of patients remain with the sustained undetectable MRD below 10 to the -4. But what is more important, and that is the highlight of this year presentation, is that there is a tight correlation, as we already learned in the era of chemoimmunotherapy, between the level of undetectable MRD and the PFS and also the overall survival, as I show you in a minute, will tell you in a minute. So patients who did not achieve undetectable MRD, in particular those who were above 10 to the -4, they had a much shorter progression-free survival. And what is more important even is that they have a shorter overall survival. So that becomes relevant for the future design of studies and for the future use of drugs, because maybe we have to introduce the MRD assessment as an endpoint in the study so that we can improve the outcome of the patient who do not achieve undetectable MRD, meant as less than 10 to the -4. So in conclusion, the study showed again and confirmed the high efficacy, prolonged time to next treatment in this with this combination treatment between venetoclax and obinutuzumab. Another presentation that was a poster was the presentation, the update of the CAPTIVATE study. The CAPTIVATE study, I remind you that it's an international study. It's only a phase 2 study. Here we heard about the 4-year follow-up. And the CAPTIVATE study is a combination of venetoclax, again, the BCL2 inhibitor, plus a BTK inhibitor, so ibrutinib. And this study has been run in, been enrolling a young patient. And at the end, the treatment was constituted by a lead-in phase 3 months of ibrutinib, followed by 12 months of the combination of ibrutinib plus venetoclax. And then the data that had been presented at this year at THA was a 4-year update of the fixed duration arm. So at the end of the 15 months of treatment, all patients stopped. There is another cohort of patients which was MRD guided, and that update has been already given in other conferences. What we learned with a longer follow-up, 4 years, so roughly the median is of 36 months off therapy, so after the 15 months of therapy. What the study confirmed is that the CR rate, that was the endpoint in this study, was very stable, and that in particular among all treated patients and among unmutated patients, where still roughly 40–50% of patients remain in CR after 36 months post-treatment, with a difference of only 5–6% between 2 and 3 years. A little bit less efficacy we saw in patients with p53 aberration, because there the patient tended to lose the CR status much more rapidly, so that a lower percentage of patients, 30%, will be in complete remission after 3 years after treatment. Again, this is a study where the design of the study was aiming at reaching deep responses. So MRD was a piece of information, a relevant piece of information that was obtained in this study. And also in this case, we observed a continuous loss of the MRD, undetectable MRD status, so that now 3 months after treatment, 3 years after treatment, only 21% of the patients remain in undetectable MRD state. In terms of PFS, the fixed duration continued to provide durable high PFS rates, and in particular among unmutated patients, where almost 3/4 of patients, 73%, remain progression-free at 4 years of follow-up, which is very similar to all patients altogether, 79%. Again, as indicated earlier, patients with p53 aberrations, either p53 mutations or deletion 17p, they progress a little bit earlier. So only 2/3 of patients, 63%, remain free of progression after 4 years of follow-up. And again, the level of MRD confirmed to be predictive of response. So patients who achieved undetectable MRD remain much longer. So 90% of patients are still progression-free after 4 years, in contrast to 66% among the patients who did not achieve undetectable MRD. The overall survival remain also very high, and what we have and the time to next treatment as well. So 84% did not need the treatment, another treatment after 4 years. What is interesting in this study is that by design, patients who relapsed and needed treatment could be treated either with ibrutinib if they had a relapse after less than 2 years from the end of treatment, or again ibrutinib plus venetoclax if they had a relapse after more than 2 years. Most of patients have been anyhow treated with ibrutinib, so we have now 19 patients who progressed and have been treated, 17 evaluable, and among the 17, all patients virtually responded with even CR or at least a PR, as we would expect when treated with ibrutinib alone. One patient, unfortunately, was diagnosed with a Richter transformation 1 month after restarting ibrutinib, and one patient who had stable disease due to a short follow-up after the restart of treatment with another reanalysis, recent reanalysis showed also a partial response. So really reassuring that after I plus V, ibrutinib plus venetoclax, patient can be rescued if progressing in using ibrutinib alone. We are still unfortunately missing data with the reuse of the combination. So again, also this combination remains a very promising combination, in particular probably among young patients, among unmutated patients. And so this is again another combination that is becoming part of our armamentarium for the future. Thank you very much for your attention.